It's a great pleasure to have Dr. Kerdel on our program, who is the director of the Dermatology Inpatient Service in Larkin Community Hospital and also professor and vice chair of the Department of Dermatology at the Florida International University. And to be honest with you, Dr. Kerdel does not need an introduction because he is really one of the giants of dermatology, and he basically a towering figure in the United States and also internationally. This is an international program, and just for the audience, it is very important to know that he was basically the president of the International Society of Dermatology between 2010 and 2013. He had numerous high positions in dermatology and has been extremely prolific in writing of papers in scientific work and in medical dermatology. So with all that, we are extremely honored to have him on the program, and he's going to talk about technique and introduction to dermatology. With all that, thank you so much, Dr. Kerdel, coming on to this program, and please give us your presentation.
Dr. Korai, thank you for your kind words. It's to be able to speak to you on a fairly sort of elemental talk about a few things you need to know when you start in dermatology. And some of this may be very old to you, but I think that you'll find that some of the things that we think of in certain areas, for example, acne will occur in the face, chest, and back, but it won't occur in the extremities. It's very, very important to look at the lesions per se and describe them so that we can sort of more or less or reach a good differential diagnosis. So, when you're talking about regional inspection of the skin, certain diseases localized to certain parts, and I said, acne would occur in the face, chest, and neck, but not on the hands and feet. So the distribution of the disease is very, very important in giving us clues as to the correct diagnosis. And that's something that you would learn sort of fairly rapidly. So regional inspection, would include the distribution, the evolution or involution of the lesions, the absence or presence of grouping, the configuration, and certainly the color. So these are all things that are obvious or run through your mind, but things that you really have to be able to determine so that you can describe the lesions. And I always say that when you describe the lesions, imagine somebody being on the phone, on the other side of the phone, and not actually seeing the patient, and see how you can describe it, and the person be able to determine or be able to reach the diagnosis. Now, when you look at a lesion per se, a lesion can be primary or secondary. And what do I mean by primary or secondary? Well, primary lesions can be macules, which are flat, papules, which are solid elevations, a plaque, which is a broad papule, which is a deep-seated or elevated mass, a vesicle, which is a fluid-filled elevation, and a pustule, which is the same as the vesicle, but it's pus-filled. So those are primary lesions. And what is the difference between a primary and a secondary lesion? Well, the secondary lesions are the ones that are the result of the intervention of the patient, when the patient scratches it or rubs them, etc. But let's go over some of the lesions, and here you can see what a macule looks like. It's a flat, no palpable, circumscribed area. Usually is normal skin color, and usually it's about less than a centimeter in diameter. And examples of that would be a vitiligo or a freckle or a junctional nevus, and even a tattoo. Okay, so here's an example. This is a lentigo on the lip, on the left-hand side, and maybe some vitiliginous areas on the hand. So that is good sort of examples of what macules may look like. Now, going into papules, we're talking about lesions that are raised, okay, that are usually less than a centimeter. And it's good if you want to determine whether a lesion is flat or raised to shine a light from the side, and actually would create a shadow, so that would determine whether the lesion is actually raised. If the lesion is depressed and it actually sinks, it could be a depressed papule. And then, examples of what a papule would be: a basal cell or molluscan lesion. Clearly, those would be papules. So here's with a cherry hemangioma and maybe lesions of maybe lupus or lichen planus, I'm not sure, on the right-hand side. But again, those are papules. Okay, a nodule is really a larger papule, be any size, and can be deeper than a papule. And a nodule can actually be large enough to be determined to be a tumor. So the sort of determination of something is a nodule or a tumor, it's a little bit vague and arbitrary. But anyway, erythema nodosum, a lipoma, or even a metastatic lesions can be a nodule or a tumor. And here you have some rheumatoid nodules on the hand on the left-hand side. On the right-hand side, you see these sort of inflamed nodular or papular lesions that you see in patients with hidradenitis suppurativa. Section of pus in the dermis or epidermis. If it's very large, we call that an abscess, and if it's small, we call it a vesicopustule. Okay, so folliculitis, impetigo, even acne would have kind of like a vesiculopapular lesions sometimes. And here's some examples, and you can see they're kind of probably pustular group lesions in a patient with maybe herpes zoster or herpes simplex. We can see the pustular lesions that can be seen in patients with psoriasis or generalized exanthematous pustulosis, and probably a lesion of chickenpox that is going through the sort of final stage and becoming a pustule on the right-hand side. Vesicle fluid-filled papule, superficial, thin-walled, and can be intradermal or subepidermal, but can be sort of subdermal. So it depends on the area of the epidermis with the collection of the fluid, whether we call it subepidermal, so under the epidermis, or in the actual epidermis itself. And we have various herpes conditions, simplex and zoster, eczematous conditions such as dyshidrosis, and even contact dermatitis. So that you can see that this is vesicular lesions on the right-hand side of a contact dermatitis, and you can see these are linear, and this is the sort of thing that you may get in a patient that is exposed to poison ivy, whereas you can see that the person with herpes has this erythematous lesion that has group vesicular structures in it, and therefore that's very, very classic for a herpetic lesion, be it herpes simplex or herpes zoster. Patch is really a large macule, really larger than 1 centimeter, and again, port wine stains and vitiligo are good examples of that. And here we have a large area of vitiligo. And then a plaque is something that it usually is elevated. It's usually larger than 1 centimeter, and it can actually be the result of the confluence of several papules forming this plaque, and it can be depressed. You can have an atrophic plaque if the area is depressed, and then you can have that in psoriasis, in eczema, and tinea, can have this sort of plaque, which tend to be elevated. And here you have a lesion of psoriasis on the left-hand side, and then on the right-hand side, you can see there's this depression in the middle of the forehead in this girl that has probably uncut de Savre, which is a form of deep morphia, where you can get this lesion in the central of the face. So this is oncocytic, which is a particular form of morphia that occurs in young individuals for most part. So bullae are localized fluid collections, usually larger than 1 centimeter, and really it really is a form of a large vesicular, and they can be flaccid, like you have on the right-hand side, or they can be tense, like you can have on the right-hand side. So the left will be flaccid, the right will be tense blisters, and obviously the left-hand side will be pemphigus, whereas probably the right-hand side is bullous pemphigoid. So tumors are usually greater than 2 centimeters in diameter. They're really exophytic, so they're above the skin, although you can have large tumors that can be in the undersurface, and you can feel that. And occasionally, instead of calling that a tumor, it's called a mass. A plaque is usually flat, whereas a tumor is usually more of a sort of exophytic mass that can be seen in the skin. So, you can have cervical nodes that can be sort of more of a mass, whereas in fact you can have a tumor of mycosis fungoides, which could be a real sort of tumor. So, it is a matter of really almost semantics. But here you have, sorry, let me see if I can go back. This. Okay. Here on the left-hand side would be like a tumor, so maybe a hemangioma of some sort, and then obviously this is an example of a Burkitt's lymphoma in a African. It would be like a large mass. So I think by now you realize that as you start dermatology, there's a language that we tend to use that you have to get very comfortable with, so that we can all communicate and understand each other. A wheal is usually seen in patients with urticaria, and the characteristic of a wheal is that plaque or a papule, but it disappears within 24 hours, because it really represents dermal edema, and as the condition improves, the lesion disappears. So here you can have mainly urticaria or urticaria pigmentosa can present with wheals. And a cyst is really the difference between a cyst and, say, for example, a bullae, is that in a cyst you have a cavity which is actually lined by epithelial. And the cyst can contain materials such as serum, pus, keratin, organisms. And it says here it feels like an eyeball, but I don't think anybody has actually grabbed an eyeball unless, you go hunting and grab the eyeball of an animal you just shot, because I don't think you'd be grabbing your own eyeball. But anyway, just imagine how it would feel if you were to grab an eyeball. And here is a pilar cyst, or it's similar to an epidermal inclusion cyst, but it's in the head, and you'll soon find that the wall of the cyst is a little bit different from the epidermal inclusion cyst. It's a pilar cyst. So the secondary lesions, as I said before, are really the results of what the person is doing to the primary lesion. So here you can have scales, you can have crust, you can have erosions, the lesions can ulcerate, they can fissure, you can have excoriations and abrasions, scar, you can have pigmentation and lichenification. So while, it's difficult to form scales, clearly I think that, constant rubbing or manipulating the lesions can result in the secondary sort of changes that we see. And it's very, very difficult, if not impossible, to actually determine a diagnosis by just looking at the secondary lesions. So you almost have to sort of guess what's happening. So here you have on the left-hand side maybe a candida interdigitalis, or it's candidal infection between the finger webs, and maybe a patient with primary herpetic lesions on the lower lip, or something like erythema multiforme. And these be really kind of erosive lesions in the fingers on the mucosa. Here you have ulcers. Probably the right-hand side represents a basal cell carcinoma, or the old term for that would be a rodent ulcer versus maybe a venous ulcer on the left-hand side. Okay, and then lichenification, the term comes from the bark of the tree, as you can see on the left-hand side. It's lichenified, and this is exactly what happens in the skin. If you rub it, if you scratch it sort of badly enough, I guess, or often enough, then you can actually make the skin lichenified, as you can see on the right-hand side picture. So scale, you can have fine scale, such as seen here in a patient with the color. Excoriations, which are often linear and usually the secondary to a patient's scratching. And you can see this very clearly in patients such as this one with atopic dermatitis. And then the scar is a collection of connective tissue that's new, and it can be either hypertrophic or atrophic, and really implies that there is actually damage below the basement membrane. So there's dermal epidermal damage to produce a scar. So this is a fairly extensive dictionary, but you have to become sort of fluent in it in order for us to be able to speak to each other. So a lot of the differential diagnosis will be based on primary lesions, and you should be able to communicate this with others. And you really have to be as specific as possible, because it is not good enough to say somebody has an erythematous lesion. I think the color is very important. As you know, you can have something that is erythematous but very purpuric, like in the case of vasculitis. You can have erythematous be like in psoriasis, or you can have a pink, yellowish hue to a lesion of pityriasis rubra pilaris. The same applies to hyperpigmentation. Are we talking about blue, black, brown, gray? So it's very, very important to actually describe the lesions as specifically and as accurately as you can. Now, having said that, I mean, that's a very basic way of looking at what we're going to see in the skin. However, when you start dermatology, you'll find that you really have to master the second part of the talk, which is the dermatologic diagnostic procedures. And the reason for that is that not only are they easy to perform, but they really are very painless, and there's really nothing invasive about them. They can be done at bedside, and they do provide with a very rapid and excellent one to make diagnosis. So what are the dermatological procedures that you have to learn? Well, first of all, you have to learn how to do a KOH, or potassium hydroxide prep, which is done mainly for fungi. You have to learn how to do a scabies prep, a molluscum prep, a Yang smear, a Woods lamp exam, a hair pull, and looking at the hair shaft. And certainly you need to know how to do a biopsy. So let's look at this. The Woods lamp exam is again very easy. You have to have a dark room. If there's some light in the room, you're not going to be able to appreciate fluorescence. The Woods light is a 365 nanometer source, which is a UVA range, and again, you shine this light onto the skin, and you might be able to see if the patient has hypo or depigmentation. Here you have a patient with vitiligo that clearly has no pigment in those patches on those macules on the face. And here you have a patient with erythrasma, where you have this coral red fluorescence that can be seen. So you can, if you look at this, you could say, well, maybe it's a tinea, but you fluoresce that, and you know that's erythrasma or a corynebacterium bacterium that has these porphyrins associated with them very rapidly. Now, moving on, you have a patient that has, as you can see, a primary herpes simplex lesion, and a patient that may have primary again, herpes simplex, but usually when you encounter that virus for the first time, you can get something called gingival stomatitis or herpetic gingival stomatitis, that can actually involve the entire oral mucosa. It can be extremely painful, and patients can have difficulty eating while while this is happening. And it's usually the first encounter in the adults or maybe in teenagers that first encountered the virus. And here's another example of a herpetic gingival stomatitis with a lot of erosive lesions in the lips as well as the soft palates. Now, this is a patient that has also herpes, but this patient has pemphigus foliaceus, and this is called Kaposi's varicilliform eruption. Sometimes some patient gets in the setting of atopic dermatitis. We call that eczema herpeticum. It's really the same thing. It's compromised or is immunocompromised, and therefore the herpetic lesions spread like wildfire, radiated from the primary source. Another case of herpetic gingival stomatitis in a patient with pemphigus, and you can see this pinpoint sort of lesions that is very, very suggestive that indeed there is a herpetic complication to this. This patient, even though you can see there is some sort of crossover from the midline, does have a very classic B1 type of herpes zoster. And please note that the vesicles, or the bullae, that is the largest lesion in the forehead, it's a little bit, has more of a blue hue, and that is because the process histologically can be a little bit deeper in herpes zoster than it is in herpes simplex. And again, this sort of close-up shows you that in fact there is probably more vascular component to the lesion than you would see in a patient that has herpes simplex. Now again, showing a group vesicular lesions in herpetic. And the reason that I'm showing you this, and this is the final one, showing you what's called a dew on a rose petal, which is really what we would see in a patient with primary varicella. And again, all these lesions can be studied, and we can determine whether the patient has herpes. This is again another patient with varicella, showing sort of lesions in different stages. As you know, they'll come at different times. So in one patient, you could have vesicles, pustules, papules, and crusts, as you can see in this patient. So in order to determine whether a lesion is herpetic, in order that you can do a Zank smear. A Zank smear will not tell you whether this is herpes simplex 1, 2, or varicella zoster, but that clinical component will help you there. And one simple rule to remember is if a patient has a recurrent lesion, it probably represents herpes simplex rather than varicella. So the repetitiveness of this does help establish the diagnosis. So in order to obtain a Zank smear, you have to break the blister and scrape the base of the blister. Then you do a smear, and that smear, you let it dry for a little bit, and then you add Giemsa stain. You wait exactly a minute and a half, and then you rinse it off. Leave a little bit of water where the Giemsa has actually adhered to your smear, and then place in that smear a cover slip. And you're looking for the cytopathic effects and the virus has on the keratinocytes. And you may see something like this, and you say, well, there's a lot of little cells here, and then there are a few kind of things that are bigger than what I've seen before under the microscope. And here, as you can see, there's a little more follicular leukocytes, and you see two very big cells that have a very prominent cytoplasm, and you can see that inside there are multiple nuclei that are kind of bunched up together. And here's again showing the difference in size between what a neutrophil would be and what two giant cells would be in a Zank smear. And the same thing, and you can see how here in this large cell, there's on the top there's a neutrophil, there's an stuff, but you can see how there's sort of the nuclei kind of bunched up rather than separated, and that really is a very classic presentation for a asancomia. Now here you can see histologically where those cells would be and why you have to scrape off the blister, because you can see that there is, a breakdown at the epidermis, but you see at the base of the epidermis dermal junctions where most of the multinucleated giant cells, which are those large blue cells, are, and that's why you really do have to scrape the base in order to obtain an adequate sample. And here you can see the difference in those cellular structures that contain multinucleated cellular structures. And, asancomia may be also helpful. You can see that we talked about flaccid blisters in the case of pemphigus, but sometimes it's not a bad idea to do this. And you could, again, another patient with a classic presentation of pemphigus with eroded surfaces, and histologically, you will see this acantholysis, or this sort of process that splits the epidermis really at its base, and the cells become all rounded up. And here it's a classic histological finding. But asancomia, as you can see here, will show a large number of acantholytic cells, which is these rounded cells, and may help you also with the diagnosis, particularly if you have another differential diagnosis. Moving on, here we have a patient that has, you can't really see it in this picture, but it has kind of like almost like a dryish sort of fine scale involvement of the hands, and maybe in the creases you can see it. A patient with clear onychomycosis, or fungus of the nails. A patient with a tinea corporis, or ringworm, and clearly the clues here is that you see this sort of annular lesion, but in the central part of the lesion is not uniform. There's some areas that show normal skin, some areas show this sort of infiltration almost into the hair follicles, and when that happens, we call that Majorque's granuloma. And again, another patient with these annular lesions with irregular contours inside of the annular. These are all examples of tinea. And this is where your KOH prep it's important, okay? This is the premier way of diagnosing fungal and yeast infections. The organisms are present in the scale and crust, and all you got to do is scrape. And it's really very frustrating when I get asked to see KOHs and they're like 3 or 4 scales. You got to get a lot of scale into your prep, and you place a KOH. Most of the KOH formulations used today contain DMSO. That's to allow the dispersion of the keratinocytes, so you can see the either the spores or the hyphae easier. Used to be in the good old times that we used to use 10 or 20% KOH, and we used to have to heat it up. With the DMSO, you don't need to do that anymore. So do not heat the KOH if the KOH you're using contains DMSO. And here is something called a Schwartz-Lampkin prep, and this is just a 2% KOH, but it has a surfactant and Indian ink incorporated into it, and it makes it easier to actually see the hyphae. And you can see that these things are actually branching at right angles. So this is no pseudohyphae. It's a real hyphae that we see in patients that have dermatophytes. And it's important. Look at this sort of double wall of the thing in order to determine whether this is actually a hyphae rather than an air bubble that got trapped in between 2 keratinocytes. Now, when you have tinea capitis, and here we have a carrion, and carrion is important because it can be very destructive, and sometimes we have to treat these patients not only with antifungals, but also with systemic corticosteroids to prevent the scarring and the irreversible hair loss that can occur when you have a carrion. Here we're looking for fungi, and here is an ectothrix. That means it's outside of the hair shaft. And I think I have a better, here you can actually see it better. You can see that the hyphae are outside of the hair shaft. So that's an ectothrix. asked to compare to a hair shaft, and here is full of this sort of spores, which is an endothrix, and this is far more common. Endothrix ketone strands being the most common, mainly seen in young children, particularly African Americans. Again, KOH is very important in order to diagnose Candida. Okay, and this is you can see that this area, the diaper area, is very erythematous, weepy. But the important thing is that the folds here, if there was an irritant contact, would be spared. Here they are actually not spared, and you can see that in fact there are satellite lesions outside of the main candule. Sorry, and here it's another candule, but at least a more serious problem in a patient, obviously very pale, very anemic, purpuric lesions, probably has a fever. In a patient sort of probably with leukemia, undergoing chemotherapy, and they want to know whether in fact this patient has candidiasis. Here's his purpuric lesions in a higher magnification. But so what you can do is you could do your KOH. In the case of the candidial infection, you do the same thing you did before. In the case of the maybe candidal infection in the patient with the leukemia, you probably want to take the biopsy, and you can actually, if you're going to send it for culture, you probably want to divide it into two and put one in H&E, and the one that you're going to put in H&E, you can actually do a smear with, because that's going to go into formalin. The one going into culture, you don't want to do that, obviously, because you don't want to contaminate it. So you can divide it into two, and the bottom of the slide can be actually smeared, and this is in fact one of those, and you can see that there's heavy growth of Candida. And the reason that I can tell you this is because if you look in higher bowel, these are pseudohyphae. These are made out of spores that are dividing, creating this hyphae. They don't really go at right angles. It's more like a Y, but you can see budding yeast forms that really are what's causing the hyphae to form. And tinea versicolor, again, another prime example of why the KOH is very, very important. And here you have a patient that has this hypopigmented lesions with scale. You scrape that, and what you're going to see is the so-called spaghetti and meatballs. So you're going to see a lot of this broken up hyphae, okay, that are seen here, but you're also going to see spores. So here is the spaghetti and meatballs. You can see the meatballs there on the more of the left-hand side, and the sort of broken up hypo elements that will really help you establish a diagnosis. Now, moving on, this here is one of the things that I know that every dermatology resident, when they start, they say, I want to get a scabies prep, under my belt. But if you do, all you have to do is get a magnifying lens and look for this. See that little sort of track there, serpent? That is a burrow. You get that burrow, and that's what you scrape, okay? Because that's where the money is. If you start scraping little papules or little excoriations, you never get it. So take your time, go over the entire patient, particularly in between the fingers and sometimes on the soles, and then look for it. You'll see some of them in the genitalia and sometimes in the back, but always look for this. You see, that's where the money is, okay? And, okay, and now if you get this, and you don't realize what it is, in 2 weeks you'll be itching yourself, because this is Norwegian scabies, or diffuse sort of scaly scabies. They don't want to call it Norwegian anymore. They want to change the name. I think the people from Norway didn't like that. And but anyway, this is crusted scabies, and usually seen in patients that are living in sort of extended facilities for the elderly or patients. And this entire skin that looks like canified all has millions of organisms there. So if you touch this, believe me, you will get infected. So be aware of that. Again, a patient with HIV with crusted scabies. So in order to diagnose scabies, okay, look for the burrow, okay? Look for the burrow between the finger webs and the buttocks, the genitalia, and the umbilical. And then what you do is you grab a slide, put a drop of mineral oil, and then dip your 15 blade in that little drop and use that to slide across the burrow. Now, if you draw blood, you're going to ruin the prep. So you have to be very, very superficial, and you can almost shave off the entire burrow, and sometimes that's very helpful, or you can scrape it very, very gently. And then you look for the mite, which is usually the female. You're going to look for the eggs and for the feces. I don't know if you can see here, but in the slide, we have the mite, the dead center, okay? We have those little black pellets there, and those are the fecal material. And then you'll see that there are some oval structures, which are behind the rear end of the mite, as you would expect. They're not round, they're oval, and those are eggs. Let me see if I can show you. Okay, so here we have on the left-hand side, the back, okay? Then you have these oval structures there, which are the eggs, and then you have those black areas. Now, any of these, one or more than one, makes or establishes the diagnosis of scabies. You don't have to have all of it. And here's a better picture of what the mite looks like. Okay, kind of nasty creature, and sometimes you get alive, and they happily swim on that mineral oil for a few days if you leave them alone. Now, this is another type of parasite, ectoparasite. This is crabs, and then people come and they have itchy areas in the genital, but sometimes you can see them in the eyebrows and eyelashes, okay? And here's a crab louse, and the way to diagnose this is not only by kind of detecting the organism. This can be actually seen with a magnifying lens. You don't actually have to look into the microscope. So this is a louse, this is a crab. It's kind of a sort of a louse that went to the gym and got all little sort of chunky, stubby, and you can see how it has these legs that enables him to go from one hair to the next. And this is the different. This is the body of hair louse, which looks very, very similar. And again, these are things that you'll be able to see. You don't really almost have to do a prep here because you might be able to see sort of just using a magnifying lens. But you should look for this. These are nits, okay? And they're just oval things that have a sort of plug at the end. And sometimes it can be confused for hair casts. But look at the hair that has nits, and you'll see that there is like these oval things, and they really do help you establish a diagnosis. You can see here that the louse is about to come out. The plug is actually being removed. And here's an electron microscopy, scanning electron microscopy of a nymph, which is a sort of a very sort of early head louse. And then we have molluscum lesions, and you can see this is a young child with molluscum. And you don't need to do this because this is fairly classic because the lesions are very discrete. They're umbilicated, and look for the umbilicated nature of this in order to establish a diagnosis. But you actually can express the material that is in that umbilicated papule, and you can stain it with Giemsa or with rose Bengal, and you can look for molluscum bodies. And here's a rose Bengal showing those sort of keratinocytes that are very heavy, and that is a positive molluscum prep. You can see here. And I think this is a Giemsa showing the same thing. So you can, if you are not certain as to what you're looking at, you can actually express a molluscum lesion and do a prep and look for these molluscum bodies. Hair, I think it's important because you have to determine whether the anagen, catagen, or telogen, it's either growing or in a stationary phase, or it's actually in the going away or being lost phase. You can also detect the hair shaft abnormalities. So right here is monelythrix, which is this sort of beating. So if a parent brings you a child and the child maybe has a family history of sort of deficient hair or almost alopecia-like, and you look at the hair shaft, you already know the diagnosis because this is monolithic. And you have trichorexis nodosa, again, a hair shaft disorder that can be easily be seen. Again, you don't have to put it under the microscope. You can do it with using a magnifying lens, but this is kind of very nice to look under the microscope and see this type of problem. Now, the final part of the talk is skin biopsies. Obviously, we do like to use local anesthesia. I mean, some patients are crazy enough that they don't want it, but usually by the time you start, they do change their mind rapidly. And really what you are trying to get at determines what type of biopsy you want to use. Obviously, it is really a very bad thing to do a shave biopsy when you think that the process may be in the deep dermis or in the subcutaneous tissue, because you're not going to see it. So there are, for this purpose, several types of biopsies. One is a shave biopsy, which is mainly superficial, but you can do a saucerization, which is a deep shave sometimes in certain circumstances. If you think that the patient has something that involves not just the epidermis, but the dermis and going into the subcutaneous tissue, then obviously a punch biopsy is preferable. Excisional biopsies, when you can take the whole lesion, it's really a very good thing to do. If particularly you're considering a malignant pigmental lesion. And when something is very big, then you can take part of it and do an incisional biopsy. And finally, in an ulcer, it's good to have not only part of the ulcer, part of the border of the ulcer, but also the adjacent normal skin. And we call that a wedge, which is kind of taking like a little piece of a cake from a lesion. So here's a diagram of what a punch biopsy would be. Let's just say superficial top of your right hand side. A deep saucerization shave biopsy, you see it's attempting to take everything out with a very deep shave, and then the excisional biopsy where it's actually removing the whole amount, or removing the total lesion. So here we have a shave biopsy. We usually take the blade, and some people use this fancy it looks like shaving blades, but 15 blades is usually what most people do. And if you have something like a basal cell carcinoma where you know most of the activity is going to be on the surface, then this is an ideal way to biopsy. Okay, deep saucerization, something that is pigmented, but you're really not suspecting too much, but you want to get most of it out, then you can do that way. If at all in doubt, it's probably better to do an excisional biopsy. But deep saucerization can also be helpful. Again, showing these fancy blades that people use that can be actually very nice in order to do shave biopsies. Punch biopsy is a punch, and again, that enables us not only to see the epidermis, but quite deep, and sometimes even all the way down into the fat. And there are different sizes of punch. But here, as you can see on the bottom of the right-hand side, here there are some histological changes that are occurring all the way in the subcutaneous tissue, and this is why you can't just do a shave biopsy. So the punches there are probably a 3 or 4, a 5 or 6 millimeter punches, so you can choose which one you want depending on the size and what you want to sample. To me, it's almost criminal not to suture these things unless there is a chance that you're biopsying an infected focus, that where you're going to have the lesion undergo dehiscence. I think that if you do a punch biopsy, you should always suture it because the mark and the morbidity associated with leaving it alone is quite considerable. Is an excisional biopsy where you say, okay, I don't like this thing. It's a pigmental lesion. It has irregular pigmentation. It's quite large, so I'm going to take it off. And so I'm going to do an elliptical incision. You can see for the width, you usually have to do multiply times 3, so you can get a nice sort of excisional biopsy there. And obviously, a patient with a melanoma getting an excisional biopsy that's going fairly deep. So you want to go down all the way to the fascia, and the number of millimeters that are taking around the lesion, has changed somewhat. It used to be very large. Now people are going for more conservative clearance of the lesions. So, and again, here's a patient with pyoderma gangrenosum, and you say to yourself, well, what type of biopsy am I going to do? Well, clearly, you don't want to do the middle of the ulcer because that's just going to be necrotic tissue. You don't want to do the adjacent because then you miss the pathology. Here's where you really want to do a wedge biopsy. So you take a sort of like a the front or the triangle part of the wedge goes into the ulcer, and then you're going to take from the larger portion from the normal as well as the border of the lesion. So here's with a wedge biopsy. And this one, because it's open and it's secondary impetiginized, maybe this is one about biopsy that you may not want to suture. But anyway, the wedge biopsy would be a very good biopsy to do in this setting. Having said that, I think this is the end of the presentation. And I don't remember from last year whether there's actually the possibility to ask questions. Laszlo?
Yeah, I'm here. Thank you very much, Dr. Kerdel. It was absolutely fantastic.